History of what might be called coercive approaches to mental health actually go back to the very beginnings of mental health, organized mental health care here in the United States. In the colonial and federal periods when there were almost no psychiatric hospitals, or for that matter hospitals of any other kind in the American colonies and early republic, the majority of people with mental illnesses, and what is an eerie echo of the situation we face in many areas today, found themselves confined in jails and almshouses, burdens on the public wheel, but also unable to live freely among their neighbors. With the inception of state hospitals and the great wave of building state hospitals comes along in this country in the second third of the 19th century and continues into the middle of the 20th century. But at the outset, when the first of those great facilities is constructed, there was only one way in, and that was via involuntary commitment. You could not voluntarily sign yourself into a state hospital in the 1830s, 40s, 50s, 60s, 70s, when these facilities were first opened. Only in 1881 does one of our states, Massachusetts in this case, think that perhaps there might be a different route. That the first statute comes along that permits voluntary hospitalization in state facilities. New York follows quickly thereafter in 1882, but into the 1960s and early 1970s, it remained true that the majority of patients hospitalized in psychiatric facilities in the United States were hospitalized involuntarily. And voluntary patients were a minority of the population. We went through a reversal of that phenomenon in the late 70s, 80s, and 90s, and now we're pretty much back where we started from for a complex variety of reasons. In many states, the majority of patients are again there involuntarily, and in some states, the majority of patients are actually forensic patients, and they're under a criminal status. Indeed, until the mid-20th century, many states in this country had written into their commitment statutes a provision that said if you were involuntarily hospitalized, you lost your decision-making powers of all sorts. How to spend your money, where to live, whether or not to marry. You weren't even allowed to vote. And you had to affirmatively petition the courts to have those rights restored to you when you were capable of doing so, assuming you had the wherewithal to take the issue to court in the first place. The second, of course, foundational assumption that I think underlies what has been a largely coercively oriented approach to hospitalization for so much of the history of this country are the fears that are rampant in our society that mental illness equates with violence. That mentally ill patients are preternaturally dangerous, and that we all would best be served by putting them away somewhere behind strong walls and as far away from us as possible. Which in part accounts for the siting of so many of the psychiatric facilities in this country in places remote from large urban areas. If dangerous, then of course we shouldn't ask these people whether or not they want to come into the hospital. We need to protect ourselves after all. We should simply put them there regardless of what they say. Part of that movement for statutory change was explicitly focused on reducing the use of coercive techniques with people with mental illnesses and developing voluntary and, whenever possible, community-based approaches to care. So by 1979, every state, either by statute or here in New York, as in a few states by court decision only, limited commitment criteria to danger to self or others. By the mid-1980s, most states had in addition adopted some kind of rule actually restricting involuntary treatment of people even after they had been involuntarily hospitalized, so the individual decision or autonomy. And I can just in a blanket way tell you that although there's significant variation from country to country, as a general trend, these trends are worldwide on this point. So the expectation of reformers in this very active period of change, late 60s, 70s, and early 80s, was that involuntary hospitalization would become rare. Some people talked about abolishing involuntary hospitalization, not needing it anymore. That as a corollary, most treatment would be voluntary, and coercive approaches, even beyond hospitalization, would simply wither away. We develop good outpatient services, we wouldn't need them anymore. But that didn't happen. Coercive approaches, as you will see from the presentations here this morning, have not disappeared. Indeed, although it's hard to quantify and compare across decades, they may not even have diminished. But the locus of coercion and lesser forms of pressure that we might not want to call coercion, but we might denominate pressure or leverage or encouragement of a variety of sorts, has moved from the institution to the community. And it's the focus on the use of leverage techniques for gaining patients' adherence with psychiatric treatment in the community that is the focus of our attention here this morning. Ultimate question that we will need to grapple with ourselves and as a society concerns the legitimacy of these techniques. And this is where one moves from data to values and policy, and probably where we will have a significant amount of discussion.